this is a 72 years old male. He presented with angina and 2 episodes of almost a syncope. He has a history of hypertension, dyslipidemia, smoker, type 2 diabetes, and also hypothyroidism. And the echo evaluation showed the preserved left ventricular ejection fraction with the 55 with some kind of left ventricular hypertrophy. So this is the 3D reconstruction where we can see a significant calcification on the left main and also on the LAD. So this is the left main.
Left main and curve reconstruction. We can see
that there is not significant calcification on the osteums, but yes, as Dr. Ganun described, there's a rich lipid plaque on the middle segment of the LAD and also significant calcification there. Here we have the circ. I think it's almost the same. We can observe here the calcification on the left main. We suggested for him surgery would be probably the best option because he suffered from a left main lesion, a very long lesion on the LAD, calcified with a mild lesion or moderate lesion on this significant OM without a significant right coronary artery. So probably it's surgery would be according with the guidelines the first option to be considered in this patient. However, he refused and we decided to offer him to do PCI to the left main and to the LAD as a first option, and then to consider, as I told you before, what to do with this marginal branch. So that's why we suggested to modify this plaque with intravascular lithotripsy. So with this regard, we decided to go by femoral. We did an echo guided puncture. So this is the angio where you see the calcium of the left main, the significant stenosis there, significant stenosis of the LAD, and this moderate, in my opinion, plaque on the obtusa marginalis. Next. So we wire the two big vessel, first the LAD, next, and then the circ. For doing IVUS next. So here we are. IVUS crossed very easily.
We are at the distal segment of the LAD. We can see a severe stenosis at this segment, mixed plaque between lipid, fibrous, and severe calcification, especially at the superficial and deep phases of this artery. The severe stenosis extends to the middle and proximal segment of this artery. The LAD is 2.8. So I think that the 2.75 stent will be suitable for this segment. The left main is a 4.5 mean and with a severe stenosis.
Okay.
Finally, sorry, the circumflex artery, the pullback of the circumflex artery confirmed that it has a moderate stenosis at the ostial segment with also superficial severe calcification.
Wait a minute.
That's all.
So we have two wires when we are live. Well, also in our regular cases, we make a bend for the secondary wire. So you don't have to put anything else because it's a tactile sensation. Which wire are you using in this moment? This is 3.5 by 12 as all the balloons. But we are here. We are from the ostium. I will start the light lithotripsy. So 10 seconds. Okay. So after 4, we inflate to 6. We would allow the patient to recover. So the blood pressure is okay. Out, up to put the gas out because it's important not to have bubbles inside the device. Now it's okay. So I'm gonna induce again lithotripsy for 10 seconds. Then Gustavo is gonna inflate to 6 atmospheres. Now, and then deflate. And the patient is gonna recover again. And here in Argentina, when you have authorization for doing IVL, you only have the chance to use one balloon. So what I mean is we are not having the chance to do intravascular lithotripsy for the LAD lesion. So what we are going to do in this case is to use high pressure balloon, probably scoring or cutting balloon or something like this to modify this calcium. And then we will try to finish. If it's not possible, if it is not possible, we will have to use a rotablator or something like this to modify the plaque. So we have to reposition in the wire. So we have done so far 40,
6.
now 6, and now deflate.
Okay.
So some nitro, I will disengage, wait for minutes. Let's go with another 10 pulse. Fortunately, he is tolerating very well. 36, okay.
Yes.
Deflate. So we have 120, the blood pressure. We are going for the last 30 pulse. We are trying to use all to have as much outcome as we can. Okay, 4.
4.
Let's go again. Okay, deflate. We'll recover the patient. Now 6. And now deflate. Let me check what we have here. Not too much opening, I would say. IUS, okay, great. I will pull a little bit just to go to the left main, which is the intention. This is the ostium, which is perfect. And here we have plaque modification, but not too much. It's not that easy to see. Let me see on manual view. And there we can observe some kind of calcium fractures.
Yes.
Or cracking there on 6, and they are on 1 and 11. So the lumen is okay. So I think we can use high pressure inflation with a 3.5 cutting balloon. So to fracture this a little bit more. 12, 16. Okay. 18. Deflate. It's okay. This is why I'm chosen 12. I think the distal position is quite okay. Let's go to the cranial view.
Are you going to take out the circumflex wire?
No. I will leave it there. I think a little bit deep. There is the ostium is okay. Let's go.
16,
18,
18,
20.
20.
It's let's see. It's perfectly covered the ostium. Okay, that's it. 4.5 heart pressure balloon. We are going to use. Very careful to retrieve the balloon now. I think the lumen looks nice now. 5 is ready. Okay. So I am pulling the left circumflex wire. Hopefully I can engage the circ soon. Probably I will need a little better curve. Now I think I am there. Let's rotate. Not too much.
This is a proximal LAD with a mild disease. This is near the bifurcation. There's the stent at the left main. It's a position, perhaps
asymmetric.
Asymmetric, yes, a bit expansion.
We can observe. We can inflate again a higher pressure with the 4.5.
Okay. So
the balloon is a little bit bulky now. That's why I chosen the 7 French guiding. For sure, it's gonna be a nightmare to advance this balloon in a 6 French guiding. not that easy to cross. We are not well aligned because I am out. There's a little bit distally because there is also some under expansion of the distal end of the stem. Let's go. 1, 2, 3, 4, 5, 6,
6,
12.
12.
Is that okay? And then we'll pull back and let's deflate. Yeah. And now
12.
let's go 16,
16.
18,
Yes.
20.
Yeah.
1, 2, 3, 4, 5, 6. It's okay. Let's prepare the 2.5 balloon to dilate the LAD. I think it's much better now. So this is the diagonal. This is very small diagonal. No way to put a stent there. The restenosis rate is going to be very high. We are going to use a 2.5 long stent and then probably an additional 3.0, 2.72, 75. Sorry, let's go, Gustavo. So as we did a very complex procedure on the left main.
8.
We are trying to do as simple as we can. Okay, the
12.
plate. As simple as we can here on the LAD. Once again.
12.
Yeah. Perfect. Balloons are expanding very well. Okay,
Spasm. This is spasm of the distal segment.
in the distal segment we have spasm.
Yes.
We are going to use nitro here. There is okay. Let's go. 1, 2, 3, 4, 16.
16. The wire is inside.
Yeah.
Diagonal.
It's okay.
Okay.
Deflate. We will pull the wire very carefully, very gently, being very careful. I am retrieving the guiding, just trying not to produce any damage to the proximal stent on the often of the left main. Let's see. We have a very nice outcome there. Release here. So I pull the guiding first, just not to produce any damage to the proximal left main. You see, I have some resistance, of course.
Do you want to see the diagonal or just cross it?
Maybe we can, okay, we can check it and then we will see if it's necessary to recross in case of it is difficult. It's difficult. Well, we have some no reflow there. I think this diagonal was not on my plan from the very beginning.
That's right.
Sorry, I was rushing.
Okay.
Give it some nitro and heparin.
Yeah.
And so on. This is the diagonal.
Can I inject it?
Yeah. Perfect. Let's go with the proximal stent.
I need nitro.
3.0 by 12 or 15. I think everything is okay better. We have a better flow now on the LAD. Diagonal is patent. So we will put the proximal stent because we haven't covered all the plaque there. We will use the stent boost here. And then I will post dilate this stent with the 3.0 and then I will do the final IVL if everything is okay. I have some problem here.
The twisted wire.
Twisted wires, but so my intention here is to be sure we don't have twisting wires. We can cause some damage with the guiding while pulling. So now inflate the balloon. 1, 2, 3, 4, 5, 6. 8,
Yes. Yes.
10.
Yes.
Deflate. If we go with another wire. Let me go with the 0.5. I don't know why. Probably one protruding strut is disturbing my position. It's important not to lose the wire position. To change the guiding position, I change. Deflate.
Yeah.
I will try
12, 14.
Okay, deflate. So what I did here, it was to counterclock rotation of the guiding retrieves to orientate a little bit better. and trying not to touch the inferior part of the stent. Because we will pull the guiding, inflate value 20 atmospheres. I think guiding is much better. We will try with the stent now. Not lucky enough. Let me move. No. Okay. Give me a Godzilla. Okay, perfect. I will put the guide extension over the 3.0 balloon. Now the 3.0 again is difficult. I don't want to lose the position. It's gonna be kind of difficult situation. Inflate there. 1, 2, 3, 4, 5,
Yes. 5.
6, 7, 8,
Yes.
20.
8. 20.
Okay, deflate. You see. Yeah, please save this maneuver. It's extremely important what I have done to get rid of this difficult to advance the devices on the ostium. I think it probably was the most important thing I did in this case. So now we have the guide extension there. This is a telescope from Medtronic. Let me show you the entrance there. Perfect. Here we have to be very careful on the entrance of the stent inside the guide extension there. I am in, and now it's very easy to cross. Let's inflate a little bit distally here. 1, 2, 3, 4, 5, 6, 10,
10.
12,
12.
18.
Yes.
Okay, deflate. So we will do IVUS here with the guide extension there, and then I will advance the 4.5 balloon and to post dilate the ostial part of the stent. Okay, so this is the distal vessel. No, live. Pull back.
Pull back.
I will speed up. I think it's okay. A little bit under expanded there.
Yes.
And there.
Mm-hmm.
So 2.5 de alta presión, por favor. This is proximally to the diagonal, which is okay. Very well expanded, very well positioned to the
guiding extension
to the vessel wall. So I will post dilate distally, and then the proximal ostium, and I am done. And Gustavo gonna do the IVUS
final IVUS
if it is possible. Okay, this is okay. Let's go, Gustavo. 1, 2, 3, 4, 5, 6. It's okay. 20.
20.
It's okay. Enough. One more here.
Yeah.
1, 3, 4, 20.
20.
Okay, that's it. Okay. Let's go with the 4.0, 4.5, sorry. So now we are in the right position. I will pull the balloon a little bit so I am sure into the stent, and we inflate again. Let's go, Gustavo. 1, 2, 3, 4, 5, 6. 16. Okay. Perfect. That's it. Okay. My guiding is approaching the stent, but with the protection of the inflated balloon. So now you can observe how easily the guiding is moving into the stent. We might need some nitro because we were working too hard, too many inflations. Give me nitro. Okay, now the flow is much better.
Yes.
It's just a matter of time. I think it looks really beautiful. Yeah, there is probably some plaque embolization there. Maybe we can move it with the balloon if it is easy to go distally, because it's not gonna. So we have to pull the wire and to wait for some minutes to recovery.
Yes, you're right.
So I think the case is done. It's extremely complex. I think we reached a very nice angiographic and also IBUS outcome. So Gustavo is going to close with a French angio seal here, and I'm moving to the other lab.
Thank you.